Okay, I think I will slowly get started on the event. So welcome everyone. Thank you for being here. Today we will talk a bit more about disaster preparedness and response. And this time it will be more of a panel discussion format instead of a webinar. So this will allow some more interaction and facilitates more discussion between the speakers, but also with the audience. So I see now my slides, yeah, they work. So disasters can severely impact the health of people, animals, and the environment. And this can be the case with both man-made, but also natural disasters. And then man-made disasters are more like chemical spills or nuclear explosions. And then we have more natural disasters such as floods, but also epidemics. And as I mentioned on the last slide, like the health of people, the environment, and animals, this sounds familiar to you all probably because it's within One Health. And because of these disasters, it's increasingly difficult to manage relationships within One Health because they're also, they disrupt societal functions and because they're unpredictable and very urgent. And also climate change has increased the frequency and severity of natural disasters. And on the other hand, it also changed the dynamics of how diseases spread, such as like zoonosis, but also waterborne infections and vector-borne illnesses. And all of these have a large negative impact on One Health. And to come back to this One Health approach, disasters require a multidisciplinary strategy to manage all 5 phases of the disaster management cycle, which you can see here. And one such strategy is the One Health approach. And if experts from various fields combine their expertise, we can enhance the efficiency of disaster mitigation, response, recovery, and preparedness. And this then leads to better health outcomes for humans, animals, and the environment. So today we will dive a bit deeper into the question, into some quick case studies and a panel discussion to try and answer the question, what the added value is of a One Health approach across these different phases of the disaster management cycle. This will be the outline of our program today. It's kind of the same as the previous event. So first we will start with this introduction and allows some time for people to drop in, slowly get started with our first speaker, and then presentation by 2 other speakers. And then instead of this break between the speakers, we will now have a break after the presentations to allow some time to regain strength and bathroom breaks. And after this, we will have the panel discussion, which also has an integrated Q&A, and it will be interactive with the audience. And we will again close out with the feedback session to kind of discuss what we learned today and what we will do next time. So just a short introduction to the speakers. First, we will have Amrish Baidjoe. He's a field epidemiologist and microbiologist. He's the director of operational research and epidemiology of Doctors Without Borders, and also an honorary assistant professor at the London School of Hygiene and Tropical Medicine. Then we have another speaker, Harro Maat. He's from the University of Wageningen. He's an associate professor of knowledge, technology, and innovation. And then also someone who's probably familiar to you all, Fatima Amponsah Fordjour. She is a lecturer at the Department of Microbiology at the University for Development Studies in Ghana. She is from your cohort, so we're very excited to see what progress she made since the last event. I hope you all enjoy this session. Amrish, if you're ready, you're free to start your presentation.
Hey everybody. Thank you. I just need some permissions to share my screen actually.
Oh yeah, it's the same as last time. Let me see.
So in the meantime, maybe I can start to introduce myself. Hi everybody, so I'm Amrish, and I indeed work with Médecins Sans Frontières, or Doctors Without Borders. I'm specialized in crisis situations, so everything related to infectious disease outbreaks, big ones like Ebola 2014, 2016, or Zika, well, most public health emergencies of international concern I've worked in since 2014, 2016. And today I'm going to present you a little bit on something that was never a public health emergency of international concern, but one of the outbreaks that we worked in, or actually one of the diseases we face, Lassa fever, which I was asked to highlight also kind of in the concept of One Health. So I'm going to try to see if I can make this work. I think you can all see my screen now.
Yes.
Perfect. So Lassa fever, I'm going to speak mostly about one important subject in the whole chain, not just of the many disciplines you need when it comes to preparedness, response, and recovery, but also one of the aspects that is quite often, not sufficiently emphasized, which is diagnostics. To understand how a disease transmits from person to person, or the functionality of a disease. We need to be able to detect the disease, so either the pathogen or maybe sometimes the immune response from people against the pathogen. So Lassa hemorrhagic fever, that's what we're talking about, which is caused by the Lassa virus, and it's commonly spread from other animals, mostly documented through what people sometimes call the African rat, but it's actually a mouse that is the most common known mouse in equatorial Africa. About 300 to 5,000, well, 500,000 cases annually, which is likely a large underestimate because, like I said, we don't have good diagnostic tools at hand to actually see if animals or humans are actually infected. It causes about 5,000 deaths a year. Now, sorry, I'm just gonna see how I can minimize myself so I can actually see the screen. Okay, that's better. So if you look at the cycle of when a person gets infected and the symptoms that are associated, you kind of see like in the first 2 days, fever, extreme fatigue, general malaise. And then if you progress further, in about 3 to 6 days, people can report headaches, sore throats, diarrhea, nausea, vomiting, joint pain. And also in the latter stages, you can see that people get facial edema, lethargy, or the classical hemorrhagic signs, including convulsions and then confusion. In basically all these stages, there is a possibility to kind of detect the virus, but it's not always that easy to detect the virus because the number of viral particles tend to be differing, which means that the chance of actually detecting it is not always equally high. If you look at Lassa fever itself, there's many unknowns still around Lassa fever. And it being a viral hemorrhagic fever, it's kind of like on the priority list for diseases that we should focus on, but both the options for diagnosis as well as treatment are actually quite limited. So focusing a bit on the epidemiology is that you see that most large outbreaks that we've seen and we've responded to happened in West Africa, with some variations and exceptions there. There's different lineages, or what we call sometimes also strains of the Lassa virus, which also means that your diagnostics need to be equally capable to detect most of these strains, or preferably all of the strains. If you look at the transmission of Lassa, well, 80%, as I mentioned, happens from spillovers in the community, means that, they actually come from an animal reservoir, mostly the mice that I just spoke about, into humans. And about 20% of those are human to human. And most of the time, they're so-called what we call nosocomial amplification infections, which means that actually people come to the hospital and they infect staff, or they infect other patients. And that's, of course, at most of the time quite logical, because in most cases of Lassa fever, there's actually no way to diagnose it, which also means that people for a long time or sometimes never know that people actually have Lassa, and they can also not make the necessary infection prevention measures to actually inhibit transmission of the disease. This is a bit more of a complicated scheme, so don't dive into details. It's just to say that for diagnosis, there are different options. Typically, you can detect the virus, either a part of the virus, a physical part of the virus, or you can detect some of its genomic material, But later on, as someone has an infection of any pathogen, people will develop a so-called immune response with antibody types. And those antibodies you can detect as well. Typically, there's two categories that we tend to detect: IgM, which kind of indicates that people have been quite recently infected, and after time, IgM declines, or IgG, which is an antibody class that kind of like sustains over a longer time. So in that case, you can say, okay, someone was infected with Lassa fever, but it might have been a long time ago or relatively short term. We don't know at that stage. So there's different things you can target for things like diagnosis. But of course, what you need if you want to diagnose people is a sample, ideally a blood sample in this case. But also to utilize these type of diagnostics, it's super expensive in the sense that you need a well-equipped lab where you have the, let's say the machinery to do it. But also because most of the cases happen in relatively rural areas, you first need to transfer the sample in a safe and responsible way to the laboratory. And then often you need to get the results back, which can take a long time before you get the results back, which means that typically you don't take the right measures, but typically you can also not start treating the patient right. So there's an urgent need for so-called what we call point of care tests, similar to maybe what you know about malaria potentially, the rapid diagnostic test, which are tests that are very accurate in terms of detecting a pathogen or that people were infected with a pathogen, but also super easy to apply because you just take a drop of blood, you put it on a test, and within 15 to 20 minutes, you have a relatively reliable result. Also, in terms when it comes to diagnostics, WHO, into collaboration with many stakeholders, including MSF, they have these so-called reassured criteria, which kind of look to the ideal test. So the ideal test basically needs to be able to give you results very quickly. You don't need to take complicated samples. Ideally, you have a sample that is very safe. So ideally not blood, but it's of course not always the case. It needs to be affordable. With a high sensitivity and specificity, meaning that the test always detects the right pathogen, but also it does so with great accuracy. It should be user-friendly, so you don't need highly specialized staff for it. It should be rapid and robust, and it should be as simple as possible. And ideally, it's deliverable to end users. So in the most ideal case, even a patient themselves could test themselves. So these are, of course, what we call the striving criteria. In most cases, it's not always possible to meet all these criteria, actually, or you have to compromise on some things like sensitivity and specificity. So we did a study on a new test, which was recently published in Lancet Infectious Diseases, which kind of compared a new point of care test compared to the golden standard. And basically you wanted to see, is this test really sensitive and specific? So can we really use it? And the secondary objective was like, how easy is it to use this test? And here you can see like a model of how test looks. It's basically a strip. There are some antibodies coded on this, and when a sample or a drop of blood is put on the sample, it will go through the strip and in the end reach the antibodies. And if there is virus present, the virus will bind, and basically you will see a stripe, the so-called test line, which you can see here. And of course, to actually then compare if a test is really working well, we use very more sophisticated sensitive tests that you need to do in a laboratory, which is the so-called RT-PCR, for which we have special testing kits as well. Now, the study took place in Abakaliki in Nigeria, where they had subsequent outbreaks, but also where we have a health facility that can actually provide the services needed, both in terms of treatment of patients as well as the proper isolation procedures. And we also do a lot, of course, of prevention campaigns in communities, as well as like when we see people that are infected with Lassa, of course, we can go into the community to find additional people that potentially are infected and provide them healthcare, quite quickly. So this is kind of a map, and basically, this is kind of like the procedure set that we used. And the only reason I'm showing you this is not to confuse you, but kind of to say that it's quite complicated to set this up because you're dealing with an hemorrhagic virus, and then you're dealing with it in a resource limited setting. and you are working with blood. So these are like a few red flags that for which you need to take a lot of procedures, which means that also people that actually take the blood of a so-called suspected case, so a patient that has the symptoms and potentially might have the virus, you do that in full equipment in high temperatures. So not very easy to do that in practice. And of course, we've learned a lot of that during Ebola as well, where it was sometimes even hotter. We were less prepared than we are nowadays. Yeah, basically the results were quite disappointing. So even though the manufacturer specified that the test was quite sensitive, when you took all these real-life conditions in account, we saw that the test was actually not sensitive and didn't meet the criteria for, well, being able to detect 90% of the cases at bedside, which means that the test in the end is not useful to be used in these contexts, and it's certainly not a replacement, because it might actually be that you test someone and that they are actually, they do have the virus, they can infect others, but you just simply miss it. So basically, it showed, of course, like when was this test not performing really well, when it was actually when people didn't have enough virus in their blood, which might be very early on into the infection stage, and very logical. If you have more virus in your blood, then clearly there is a better chance of getting a positive result, but the results we got were by far not good enough. And of course, that the practicalities of implementation of this test were also quite difficult, given the prevention measures in terms of wearing the so-called protective suits that people had to wear, made it also complicated to take the test, apply the blood, but then also wait for 20 minutes next to the bed, including that, there's also many other patients waiting, which means that it's not that you get cases every 2 minutes. Sometimes you are working and doing routine patient care and a suspect case comes in, so you need to wear the suit, you need to take the sample, you need to wait with the patient for quite a while and then get properly disinfected and disgeared as well. Also, you remember that I spoke about the different Lassa strains. So yes, in different places, different strains, and we're not sure because previous studies actually reported higher sensitivities, if it might actually be a different strain in this area and therefore the test performed less well. But yeah, our study showed much lower sensitivity than of the test. So in this context, it was definitely not very well implementable. So basically, there's like quite some elements in terms of discussion. Our context is quite specific, both because of the strains, as well as that you work in a relatively low resource setting. So the validation context can differ. The user friendliness, well, you need to wear the full personal protective equipment, so it's to prevent doctors getting infected and healthcare staff getting infected, but it's also very time consuming and very uncomfortable, speaking from experience, to wear it. I mentioned the lineage difference already, but also what we say, if you have more virus, then cases do get detected, but we get patients in all categories of severity, which means that we might miss cases as well. So concluding, this RDT is not recommended. We won't use it. Yes, there is a marked improvement in sensitivity and user friendliness that is needed actually for us to adopt these quick rapid tests. But there remains an urgent need for better Lassa fever diagnostics, because actually there are quite some products in the global catalogs, but many of them are not meeting standards, and basically it's not a very high priority. And it basically means that, in low resource settings, we have a limited ability to actually detect if people are infected, but also a much more limited capability to do more wider surveillance, which means that can we look at natural reservoirs, can we better understand how transmission between animals and humans happen, and how we can prevent it better. Of course, the general recommendations for Lassa are already always like, if you live in an area where you have routine outbreaks, make sure that you create a nice unfriendly environment, which is super difficult, of course, but one of the key recommendations is, of course, making sure that you don't leave food around, and other things like that. So that's actually it, because I had a very short time. So leave it up to here.
Yeah, thank you for your presentation. very interesting to hear about like the background of the diagnostics of Lassa fever and how actually the characteristics of the disease kind of make diagnostics harder. So thank you for your presentation. Yeah, they're quite short, all of them, to allow more discussion, but I thank you all for putting in the effort to keep it short. And yeah, I think we will already move on to the next presentation by Fatima. So if you're ready, Fatima, you can go ahead.
Thank you very much. Okay. Thank you once again. Good morning, good afternoon, and good evening, depending on your country. I am Fatima Amponsah Fordjour, and I'm talking on using One Health approach in neglected tropical disease elimination. This will be the scope of my talk, and I'll briefly give a little intro on my research interest, connect NTD with One Health, and also give some cross-cutting templates on how to manage NTDs and also using One Health approach. I will therefore explain briefly how we can use the One Health approach to prepare for pandemics in NTDs. And finally, I will give a brief overview of progress reports on our TRC Global One Health research and some findings. So primarily, my research interest is in infectious disease with a special focus on neglected tropical disease. And an infectious disease is an illness due to a pathogen or a toxic substance. And NTDs are diseases that affect the world's poorest population. And normally these diseases are neglected. And some examples include lymphatic filariasis, onchocerciasis, soil-transmitted helminths, and schistosomiasis. There are other ones. I pay close attention to the human, animal, and environmental interfaces of NTDs, hence my focus on One Health. Over 1 billion people are affected with NTDs globally, and NTDs do not pose public health concern to only humans, but also the animal and the environment. An example is schistosomiasis infection, in which we have the human species, the animal species, and the environment harboring the infective stage of the parasites. So looking at the connections or the linkages between One Health and NTDs, we have to develop strategic plans to facilitate NTD elimination. In doing so, we have to develop some plans, and the first approach is developing regional or national plan that will serve as a guide or a template, and also integrating NTDs into existing platforms. Most signs and symptoms of NTDs are not recorded in medical books, even in endemic countries, so making their study and also their diagnosis very difficult. So in integrating NTDs into existing platforms like HIV clinics, vaccine centers, sickle cell units, and others, we have to revise and update these platforms so that NTDs can be eliminated. Another issue is with paucity in data on the human-animal environmental interface in NTDs transmission. So there should be rigorous research on these facets of NTDs so that data or empirical data will be available and will serve as template for their elimination. To prepare for pandemic in the future for NTD, there should be collaboration and joint interventions through advocacy, implementation, surveillance, and evaluation. So as we connect NTD with One Health, there will definitely be some benefit because we develop SOPs, we develop template and guides. So definitely we will measure some import some achievements. And normally this achievement comes in the form of using financial resources well in a cost-effective manner, and also prevention of duplication of effort. This means that works or researches that are on human, animal, and the environment will not be tackled independently. So there will be that kind of holistic approach towards their elimination. And also unintended consequences. An example is snail vector elimination in schistosomiasis infection. Usually, when the chemical method is applied, it normally affects aquatic and other ecosystem lives, but such as using natural predators of the snail so that we can remove them and also preserve the ecosystem. Results become sustainable, and also health systems are strengthened using the One Health approach in NTDs. So as these common objectives and collaborations happen, then definitely we will have people, a stable people and communities, animal world needs. And in doing that, we will all be marching towards the roadmap for 2030 in ending NTDs. So I'll give a brief overview or progress report for our TRC Global One Health project titled Zoonotic Schistosomiasis, a possible sustainer of schistosomiasis infection in Africa. So over 251 million people are infected with schistosomiasis worldwide, and more than half of this population are in sub-Saharan Africa. Despite the prolongment in mass drug administration ongoing, there is still quite a number of incidents of schistosomiasis in human population. In some part of the world, and also especially in Africa, livestock owners and their livestock live in close proximity. And this proximity or closeness has reported, there have been reports that this proximity could lead to zoonotic schistosomes in human population. And also studies have presented or indicated that there could be possible resistance to praziquantel, that is the drug of choice recommended by WHO for treating schistosomiasis. So this becomes a problem for all of us. Therefore, this study aims at determining the presence of circulating schistosomes both in livestock and their owners. And specifically, this study is assessing the prevalence of livestock schistosomes and also human schistosome, assessing some disease manifestation, especially in the livestock, because in this area, livestock schistosomes have received less attention. So we want to assess some disease prevalence, disease manifestation, how the disease presents itself, the clinical manifestation. And finally, we will organize focus group discussions for these livestock owners. And this is all towards the mitigation of the cycle of infection. So this study is a cross-sectional and random sampling study conducted in the Tolon district of the northern region of Ghana. So normally, before we enter the community, we visit the chiefs and opinion leaders in each communities. And before we got access to these communities, we connected with the disease control officers in every district and liaised with them. So we got a list from them, and from this list, we selected some communities for this study. So these opinion leaders are first of all briefed on the procedures and the intention or the implication of the study. After that, the whole community is also briefed thoroughly on the procedures and what is expected of them in this study before they consent or agree to be part of the study. After they have consented, we took samples, human and animal samples, both urine and stool, from them for schistosome examination microscopically. So this is what we saw in the community. This is what is happening currently. So it is true that livestock and their owners are living in close proximity. So the possibility of, and also the fished. So far, we've sampled over 120 human and animals for schistosomes, and a prevalence of 33%, 27%, and 75% have been recorded for Schistosoma hematobium, Schistosoma mansoni, and Schistosoma bovis, respectively. Findings from this study suggest that non-MDA compliant humans are mostly positive. So the vision of the research is not only for the annual mass drug administration for human. As we are given praziquantel for human population annually, we believe there should be inclusion of livestock in MDA biannually or annually, so that we can fight against schistosomiasis transmission holistically. And also there should be the provision of potable and segregated water systems for both animal and human, because from what we saw on the field, we realized most of the time, because of the closeness or proximity, human population and animal population usually depend on the same water source. And when you provide potable and segregated water system, this link can't be broken. This is the team. Thank you very much.
Yes, thank you for your presentation, Fatima. It was great to see the progress of your project since the last year.
Yeah.
So, yeah, thanks a lot for sharing.
Okay.
So if anyone has questions, please write them down somewhere, because the Q&A will be within the panel discussion. And then we will move on to our last speaker already. Harro?
Yes, thank you. Let me share my screen. Is it there?
Yeah, I can see it.
Okay, very good. Well, thank you very much for the invitation, and it's a pleasure to be here. I'm a social scientist from the Department of Social Sciences and Knowledge, Technology and Innovation Group. And my talk will be slightly more conceptual, although we have a program that's also addressing Africa that I will briefly mention, but I'm zooming a bit out on some of the more generic understandings of how we deal with One Health in relation to disasters. And as the title suggests, I will have a specific focus on ecologies. Yeah. So the 3 points that I try to make, first of all, is that One Health approach typically marginalizes an ecological understanding of, infectious diseases and responses to disasters more generally. Then I will say something about the skill levels, because there's an inherent problem there that is related to this marginalization of ecology, that we tend to think and act a lot on generic skills, where we basically need a multiplicity of skills. And I think that in a way connects quite well with what Amrish and Fatima have been presenting in a way. I will come back to that. And then I will give an example of how that requires other types of research. So I'm not saying that we have to fully switch our research agendas, but we need to be more pluralistic, in our research approaches. And I will introduce an approach that is known as the science shop, or wetenschapswinkel in the Netherlands. But there's other terms for the same approach. So first of all, ecology is very much presented in all the One Health and especially international agendas as an externality, as something that is literally at the end of the action cycle. So this is an image I took from the website of the quadripartite One Health Joint Plan of Action. So it's the 4 major international organizations. And as you can see, it's very much focused on improving the health system. It's very much focused on governance and national plans. And it's very much focused on, sort of data-driven approaches. And again, there's nothing bad as such with them, but they are limited, or they provide a particular view and focus on these issues that I think are not fully covering the kind of approaches we need. The first point there is that this is often suggesting a sort of separation between the human system, so to say, and the natural systems, or between human and nature, or human interest, etc. And typically that's not the case, but it's very difficult to get it out of our thinking, so to say. So in other words, we see a lot of the approaches assuming that we're dealing with a sort of generic and monolithical threat from outside that affects us humans, and we have to respond as humans, and that within the limited limits of natural resources and what nature is doing, and what the climate change, all these sort of big threats are considered to be really outside our control, and to a large extent they are. But at the same time, they are very anthropogenic, as is then also acknowledged. But I think that the consequences of these anthropogenic causes are not fully thought through in terms of how these interactions between human activities and natural disasters play a crucial role in the prevalence and epidemiology of these diseases. A related problem is that path dependencies of the health systems are part of the problem. And what I mean with that is that the health system, as it has been set up in well, basically across the world and in different versions and in different stages of technical accuracy and technical, let's say, effectiveness. But nevertheless, they're basically all the same in all countries, which means that they are very much pillarized within typically a Ministry of Health. They have a very selective number of training facilities, so it's nursing schools, medical faculties, etc. And they're all focused on the human body. And not only that, we also have a very strong commercial system of pharmaceutical companies who develop our vaccines, who develop our medication, who do a lot of good work, but they also are selective in how they address the problem and the kind of solutions they then offer. So these are the kind of things that I call path dependencies. These path dependencies are often taken for granted or not addressed at all, but they have a huge impact on, again, how we see problems and how we then devise solutions. And one of the effects, and maybe the most important effect, is that we typically tend to look at uniformity of problem definitions and solutions. So again, taking, for example, the latest COVID outbreak, yes, almost the only focus that was very common across all the countries was initially a sort of generic isolation and distancing measurements, and later on, when vaccines became available, a massive distribution of vaccines. And as we experienced the COVID crisis, all of us in different ways, we've also seen all these kind of things that went wrong, despite all the good things and the rapid response of the industry to develop these vaccines. There's a lot of things you can still say that link very directly to these path dependencies in the system. So again, a lot of good things come out of these international projects and approaches, but we typically tend to overlook the shortcomings and limitations of it. Scale is there and crucial. So as I already said in the previous slide, we tend to look at generic solutions because we think it's a global problem, and it indeed is a global problem. But the fact that a problem is global doesn't mean that it is the same in every location. And as I said, the previous speakers really showed some fine-grained types of research that address these local differentiations. Lassa fever is not very common outside the West African Lassa fever belt. And likewise, these kind of schistosomiasis problems that Fatima addressed are very ecology dependent. What that means is that basically the system, the global responses, very much try to focus on these generic problems and solutions, and not look carefully enough to what it implies for local capacity and local options and local implementations for redesigning and strengthening local health systems. And again, ecology there is crucial. I think both examples, both disease examples in the previous presentations, they didn't mention perhaps the ecology factors very strongly, but I have no doubt that they will agree that these diseases are very ecology dependent. So Fatima already addressed livestock management and the rats that are very prominent in the transmission of Lassa fever. Also, of course, are animals that live in a particular, human-made ecology. And these sorts of things are researched, but researched at the margins. So again, there is some attention for it, but we really need to increase our capacity of understanding the role of ecologies in these types of diseases. And then, of course, if we do that, we also would need a much more multi-scalar approach. So small scale, medium scale, large scale, global scale. We need it all, not just global scale kind of strategies and approaches. So I have two examples of this. This is a study that I was laterally involved in, Ebola evaluation study in Sierra Leone. And these are very simple statistics from a number of districts in the eastern provinces, southern east provinces. And what you really basically see is the huge diversity in figures. So there is certainly not a sort of uniform distribution of Ebola cases during districts and villages. And this is just a snapshot of a part of the country, and of course the pandemic was much bigger than just Sierra Leone and the east of Sierra Leone. So it's likely that this kind of variation exists in other parts and other countries where the Ebola crisis was prevalent too. And this variable impact can be explained by a number of things. And first of all, this pocketed outbreaks of the epidemic in general is very difficult to predict. So standard epidemiological tools cannot explain these kind of patterns. So that already suggests that the kind of instrumentarium that we have for understanding these disease outbreaks is limited. And for example, social science research and anthropologists, and I think Amrish also played a role there, have been contributing a lot by trying to emphasize the importance of understanding these pocketed outbreaks and these locally specific reasons for the spread of the epidemic. Then two major causes for this distributed, this patterned pocketed distribution are what I call landscape immunology. So in other words, the landscape itself often creates ways in which communities can literally isolate themselves. Rivers and forest areas, etc., make access to certain places very difficult, but also trade and other kind of interactions that typically spread these kind of diseases are much rarer or much more infrequent in these areas. So that gives them an advantage. But what exactly that is, we need to know more about. And the same applies to local capacity. And again, there's many studies who have addressed how important local capacity was for curbing the spread of Ebola. Second example is a study from colleagues in London School of Hygiene in Cambodia, which is about different viruses in pigs. And the interesting element that I want to highlight here is that because Cambodia has a large variety of forms of pig farms or ways in which farmers have pigs, from quite intensive, where the main source of income is pigs and commercial pig breeds, to very extensive, where pigs are one of the resources of food and a bit of extra income among a wide variety of other crops and livestock. And what the study really showed is that there was a big difference in the prevalence of viruses, the appearance of viruses between commercial farms and smallholder farms. And this was a scoping study, so it's limited data, but the findings were really prominent. So as is put here, these pigs were tested on a number of viruses, and yeah, basically that created a lot of interesting data. And first of all, one of the things that is already known, of course, is that pigs are associated with a diverse range of diseases. But they also, and especially in the more remote areas of Cambodia, pigs are often literally roaming around in the wild. So they are not kept in pens, and the interaction with wildlife and pigs and wildlife and humans is much more prominent, which isn't necessarily always a problem. It also sometimes creates very resilient species, or increases the immunity of these pig breeds by these kind of wildlife interactions. So the fact that these diverse livestock systems are more directly interacting with wildlife is not necessarily always a problem. It can also be part of the solution. And it's exactly what we need to know more about. So how this diversity of livestock management and modes of production affect the risks of pathogens, pathogen presence and distribution through infection and transmission. So the final point is, what does it mean for the research system? So typically One Health, and this is a picture taken from the Swedish ministries, they are typically focusing on disciplinary collaboration. That's important and that's very much needed. However, it's also limited to just focus on that. And the limitations are twofold. First of all, there's a limitation often in the more bioscience and public health sectors. So often the call is for more integration between virology, epidemiology, bacteriology, and whatever you can think of. And then perhaps at the end, also social sciences are mentioned. And I particularly want to emphasize innovation studies and history. Those are not the kind of disciplines you typically would think of for having relevance for One Health, but I think they are really crucial, and not least history in terms of understanding human ecology interactions. And I'm an historian myself, partly, and one of the hypotheses I have about history is that the modern period, let's say from the beginning of the 20th century until now, is a historically relatively short period in which we became fully dependent on an external health system for our health. So in other words, we have lost many of the strategies, tactics, and techniques for maintaining our own health within and with the capacities of our local ecologies. And that's not a sort of revisionist historical position. In other words, not saying that things in the past were better than now, but simply to assert that we can learn from history, and that history can have important lessons for us if we take that seriously. And increasingly, historians and other researchers are doing that. So what I'm arguing for is that we need to widen our scope in terms of disciplinary integration, and also include citizens, people, which then turns into transdisciplinarity. And again, there are many good examples: citizen science, living labs, participatory epidemiology. All these methods and research approaches are there. But I think we still need an extra an extra mile to get to a fully pluralistic research landscape. And for that, I want to emphasize the science shop approach. And this is, I mean, a bit of a Dutch name, although there's an international network for science shops or living labs, and all these kind of things are similar. But the point is that these kind of approaches on trying to make science not less generic. So in other words, what science shops tries to do is to work at a very small scale. So they address particular questions of particular communities. They also address questions that are overlooked or not taken into account by what I call normal science. So typically the kind of, Fatima mentioned neglected and tropical diseases. One of the reasons why they are neglected is that, the research system typically responds to big problems and generic problems. And if a disease is not widespread enough or doesn't, the prevalence is not high enough, then the research attention will also go down. But more than that, we need to address these problems within their direct disease environments and ecologies. So that then also results in a better understanding of what is locally available, what is locally doable, and therefore with more tailored, locally specific solutions. So basically what I'm trying to argue for is that we have to ask different research questions. As I said, the previous speakers have given a very interesting entries in how, as soon as you focus on, let's say, less common diseases and diseases that are very particular within particular ecologies, then we still need to widen the scope a bit further in terms of, okay, what makes these particular ecologies so conducive for these kind of diseases? It's not just accidental that they spread in these types of ecologies. And what makes these ecologies positive in terms of, or how should I say it? What makes these ecologies typical ecologies for these diseases to thrive, but also what are local options to then fight these diseases at this very same local level. So in other words, I know that there are some attempts to create a vaccine for Lassa fever, but maybe there are better ways to do that with locally available resources so that we don't, again, rely too much on the international pharmaceutical and health systems. And then, of course, this also means that we have to rethink our way of addressing these issues in terms of research questions and research approaches. That's all. Thank you very much.
Yeah, thank you for offering the different perspective. I think it will add much value to the discussion we have later. Although I might be a bit biased because I'm an ecologist, but anyways, I'm looking forward to the discussion. We will start again in a bit less than 10 minutes. So we will start in 5 minutes over 2, probably different according to your time zones, but I will post it again in the chat. So yeah, take a bit of rest before we start again, and see you soon. Hello, everyone. Welcome back. So we will move on to the discussion now. I will share my screen again, and we have a Mentimeter ready for the participants who can share their ideas over there, and then the speakers can engage through their audio and video as well. And in case some of the audience members also have something to say, feel free to raise your hand. I think you can do that with the hand gestures in the screen. So yeah, then we'll invite you to talk as well and share ideas. So I'm really looking forward to that. And let's see, Mentimeter started up. I hope you can see the screen now. and you can also, fill in your code on your own device, so on your laptop or on your mobile phone. And in that way you can, share your thoughts on this as well. It's a word cloud, so it's very short answers from the audience in this sense, but just to focus on the things that kind of, jump out of the word cloud. So for the speakers, feel free to add here what your experience is with this and why you think the One Health approach is crucial for disaster preparedness in your case. And if there are any relevant cases like with the Lassa virus or schistosomiasis, and more from the social sciences side as well. So I think while we wait for the answers from the audience, we can also already, kind of discuss with the speakers already. And feel free to share any ideas from your, expertise if you, kind of come up with these case studies.
I'm happy to kick off. So why is the One Health approach particularly crucial for disaster preparedness? I think it's a difficult question, in the sense that there's many things that are important for disaster preparedness, but all of them cost resources. They cost financial resources, they cost HR, they cost political buy-in, and I think we often forget that. It's one of the most crucial things. Like, I think as professionals, we often know what needs to be done, but there's limited political buy-in. For example, in most areas where we function, we go there because there is almost nothing. And you can see that, like, the largest public health emergencies of international concern escalated to a level that they were basically because resource scarcity. Very limited number of healthcare workers, very limited number of everything, basically. So it's a bit of a question, what does it mean when you speak about all the facets that fall under the so-called One Health approach or planetary health type of approaches? And for me, too often it's not concrete enough. So sometimes I'm a bit skeptical as well. I think it's a nice academic exercise, but in reality, there are different aspects that you need to be more concrete about. And for example, like, what Harro mentioned about the inclusion of multidisciplinary teams, that's kind of already pretty much standard practice in most international response outbreak teams. We have had social scientists and anthropologists in our teams for different aspects of epidemiological surveillance. So yes, I can collect quantitative data, but then of course, to understand what is really happening, you need specific experts to it. And most countries kind of like forgot that as well during, for example, the COVID pandemic. The Netherlands was specifically very good in forgetting that aspect and still doesn't want, for example, social scientists to be more widely included in the technical management. So it's a very much biomedical approach. But within WHO or within MSF, in large emergency organizations that typically are next to, of course, the community that is present and national stakeholders, it's commonly well accepted. To give you another example, one of the largest investments that have been made in the last 10 years was in field epidemiology training programs. And these are programs specifically that are employed on a national level. And especially past West Africa Ebola outbreak, they took an acceleration. And you see many social scientists embedded, but they're also part of the national first line of defense. With one of the key aspects being that outbreaks start and end in communities, meaning that a lot of the surveillance we do is actually community-based surveillance. So it actually happens in communities. But again, with the acknowledgement that the means that we have quite often are quite limited.
If I can add to that, I largely agree with what Amrish is saying. However, as he rightly mentions, it is quite common, or it is at least taken up very seriously in the major international health organizations and also in the response approaches to disasters. However, I'll give two examples of our current research project in four African countries, and one of the countries is Madagascar, and our project partner there is Eco Ventures, and they are, Blue Ventures, and they are an ecological NGO. And one of the reasons they engaged in our project is because they have experienced through the last 2 decades that they were working in Madagascar, that all their expertise was focused on ecology. It was coastal management and coastal ecologies, etc. But each time there was a hurricane, was a big storm, they noticed that their ecological knowledge was, well, literally worthless, because what happened was outbreaks of cholera and other injuries and all sorts of medical emergencies that had to be addressed. And they simply did not have the capacity to do that. So they, from experience, learned that their focus on ecology, although I just made an argument for ecology, I mean, is also limited in itself if you just focus on ecology. And they therefore have invested a lot in gaining more medical expertise and integrating that, but they still struggle on how to do that. So let's say beyond the kind of organizations that Amrish mentions, it's still very much single discipline or single issue focused approaches that are prevalent. Another example is from our other partner country, that's Sierra Leone, where we did a study on malaria and the ecology of malaria. And typically this is completely unknown territory for trained nurses and other public health unit staff. So in other words, they are trained at the sub-academic level, so they are nurses and social health workers and public health workers. They know about malaria as I mean, all the sort of medical basic information you need of these diseases. But if you ask them what is the place where malaria mosquitoes typically breed and rest, they will say latrines. They will say, because that's where many mosquitoes are prevalent. So they repeat the common knowledge that mosquitoes are associated with dirty water and sewage. But that's one of the typical things of malaria mosquitoes. They don't like latrines, they don't like dirty water, they like clean water. So that's an example of how that, let's say, very simple, basic ecological knowledge is still very much outside the scope of, let's say, health workers and training centers for health workers in particular that, are still very monodisciplinary or mono issue in this case, in this example, medical based or even ecology based. And I think we need a lot more effort to make these kind of integrated problem-based understandings more prevalent also in our teaching, also in our the training of professionals.
Okay, I think both Amrish and Harro has said it all, but then I would add a little. Normally, because NTD has the animal, human, and the environmental interfaces, it becomes a bit easier when you are applying the One Health approach. So maybe, however, in other cases or scenarios, it might be a bit robust. But because of the interfaces seen in NTDs, applying the One Health approach become a little bit feasible. So then preparing for a disaster or pandemic in NTD, the best approach would be to use the One Health approach. As I said earlier, and I think my co-presenters have all mentioned that it saves resources, financial resources and other logistics, and also prevent duplication of efforts. I'll use my case as an example. In the past, we would go to the field, sample humans, come to the lab, work on the human samples, and examine them for human schistosome. Then in another study, you would go for animal or water samples or any environmental samples and come and examine them. But due to the One Health approach, there is a linkage, and that there is that concept or reality that when you go to the field, you have to look for all these samples holistically and map them as to the person or the participants you are taking them from, so that you can connect the linkage or the cycle. So that is what I can say. Hello?
Sorry, thank you. I was muted.
Yeah.
Thank you for all elaborating on your answers. And I think to kind of summarize the challenges with the One Health approach in disasters, it's that we have limited resources. The politicians are not always convinced of the approach, and also there's logistic constraints. And then when you do decide to focus within this disease context on maybe ecologies, it's important to don't forget that it's actually a multidisciplinary approach, and keep working together to spread the knowledge everywhere, and also to share the knowledge with medical professionals, and to actually have a multidisciplinary approach and not still all the disciplines working separately on a topic without exchanging the knowledge. So I guess that's kind of the wrap up, and also that it's very case specific perhaps, which disaster type requires a One Health approach and in which phase probably. And from what I see in the word cloud now, it's that there's these different it's also a lot about to actually respond quickly enough, and also to prevent the diseases, and at the same time protect the economy. So I guess that these are mostly arguments for the One Health approach, which kind of understripes the importance of actually working together and not working with all different expertises separately. So thank you for sharing about that. I don't know if one of the speakers still wants to add something to the comments we have until now on screen, or that we can go to the next. I think we can go to the next one. Okay. Let's see. So the next one is how these resource constraints, which we kind of talked about the last statement as well, can be effectively managed to ensure that this disaster preparedness is comprehensive and includes human, animal, and environmental health. So how can we despite resource constraints still work on One Health within disaster preparedness? I'll let it kind of land a bit, the question, and then we can start on it.
It's an interesting question, because it depends on what part of the world you're looking at. Like, one of the key lessons, key takeaways after every outbreak is that if you want to be fast, you need to have some level of basic surveillance, kind of like in there. You need to have a workforce that is ready to kind of respond directly early on. And you need to have mechanisms in your country that kind of support that, so that you limit the amount of political constraints. You need to be an emergency framework that can make sure that the right people can take decisions at time. Now, if you look now, okay, COVID is still roaming around. It goes up and down. But if you look at which countries actually adopted any of these recommendations, which is quite common after every big crisis, I would imagine the number is close to zero. If you look again at the Netherlands, 0 investments have been made in enhancing surveillance, genomic surveillance, even basic. For COVID, for example, we screen about 10 samples per week, our whole genome sequenced. And this is one of the richest countries in the world, which shows that, like if avian influenza that we read about a lot in the news now would decide to escalate and become the next pandemic, we're further away actually than ever from enhancing a good response. I would actually say that we're worse off than before COVID in many ways, both in the resilience in our health workforce, because our public health apparatus is depleted. People are tired. The healthcare system is depleted and never managed to recover because nobody put extra resources into the health system. A lot of research is being done, but not sufficiently. And I think a lot of research has also been incredibly opportunistic, as you've seen post-Ebola and now post-COVID as well. Everybody does research, but does it actually feed into improvements? Highly doubtful. They do feed in academic papers that have limited uptake. In MSF, we do a lot of research as well. We call it a bit different, operational research. But yeah, their research has to be directly relevant to operations, and otherwise we don't do it, and we quite often do it in a collaboration with academic partners. And if you do look at the other thing, trust of society in our institutes is at an everlasting low. So yes, there are a lot of bottlenecks, and that's just like probably just looking at the human side. So this is human interventions and things like that. I think especially for avian influenza, it has been asked to do more surveillance proactively in large livestock now, especially in the US. But there's a lot of farmers that refuse to do that, and there's a strong lobby around that. It always has been the case when it comes to livestock and agriculture. It's very difficult to do any research, and yeah, often it comes to the light or above the table way too late. So yeah, how can resource constraints then be effectively managed if you have so many blockades on your path? It's a good question that I don't really have an answer to.
Okay. I would also say there should be a plan, because I think there is a popular saying, whoever fails to plan will definitely fail, something like that. So we need a regional or a national plan. And a regional because sometimes a disease or a scenario or an outbreak wouldn't be a national outbreak, but a regional outbreak. So we need a plan in tackling these issues. I'll go back to my scenario of inclusion of livestock in mass drug administration. Mass drug administration is already ongoing for humans from endemic communities. So if we want to add livestock to it, we have to map, as Amrish said, there should be surveillance, disease surveillance, and also some advocacy so that we can know the areas that needs this inclusion. So as we are sending the drugs to the humans, we can equally fuse the livestock or the animal component. So I think all these components should work hand in hand, and also there should be integration of the these platforms. They are already existing platform, like we have HIV. When you go to some country, like my country, you have HIV clinics, HIV centers, vaccine centers, sickle cell centers, and other things, which mainly focus on just the human aspect. But we can focus on the animal aspects also. And also, I made mention that when you come to endemic countries, most NTDs are not even well known here, but the diseases are very endemic, highly endemic. Most of the time, the prevalence are alarming. You're looking at our prevalence of 35, 33 and 27 of hematobium and mansona in human population. That is quite alarming in a population of 120 humans. It's quite alarming based on the WHO standard. But then you will come, interview even health personnel, and they have, little knowledge on these diseases. So disease surveillance, advocacy, by creating awareness would all help in, solving this problem. And also by linking them, resources can be well managed, because the problem here is collaboration and funding. For our project, we receive a seed funding from Wageningen University and FAO, but then it can do an aspect of what we want to do, because there's another aspect which deals with the hybrid schistosome. So then we would have to collaborate and also get funding to do that aspect. With the hybrid schistosome formation, that is the most serious aspect, because when you look at that is resistance is being built against praziquantel, which is the drug of choice used for the mass drug administration. So there should be some thermomolecular, assays to ascertain that, so that we would know whether praziquantel can still move on with treatment, or we have to look for another drug. So resources can be well managed when we combine all these things together and also look at it holistically.
Yes, I'm very much agreeing with what the two others have said. So maybe the main resource that we are lacking is not resources in terms of material capacity, although sometimes that's also a constraint. But the main resource constraint is our let's say, implementation capacity to use the combination of available resources. So I certainly would not want to raise an image that resource constraints is typically a problem of, let's say, developing countries or the low-income countries in that respect. I mean, Amrish already gave the example of avian flu, how it is now in a big problem in the US livestock system. Yeah, even in the Netherlands, which is with a high intensive livestock commercial system, is sort of completely blinding itself for these things. So there's very little being done to check and test and prepare for the possibility that something similar might happen here. Another example from the COVID era is about these health system path dependencies, as I mentioned them, is the complete ignorance of the general practitioners in the early phases and especially in elderly care. So and later on even also in vaccine distribution. So the typical response of health ministries, including in rich countries like the Netherlands, is to do it all from a centralized perspective and to ignore the local capacity that is there and the local resources in terms of, in this case, in this example, general practitioners who know their patients, who know the vulnerable in their community, and therefore could both isolate and protect these vulnerable people much more effectively. And also, when vaccines are available, be very helpful in distributing vaccines in a smart and effective way so that the most vulnerable get first vaccinated. But again, our ministry completely ignored this, and the general practitioners were hopping mad about this, and rightly so. And I still think that we didn't learn enough from that experience. So, well, again, repeating myself, the main resource constraint is our capacity to understand the implications of One Health rather than adopting One Health as a sort of nice generic principle. I mean, we all do that and we all collaborate and we tend to collaborate, but as soon as it comes to implementation, we seem to forget these lessons very, very quickly. So.
Yeah, I think we discussed almost all the answers that were already shared by the audience as well. And I think one main thing that is coming back here and also in other fields is that there's almost an overload of research and papers being published, but there's a gap within the actual implementation of the science and maybe where science is actually needed. And then, how can we actually use the science to improve the conditions and facilitate the whole approach? So as was said, it depends on which part of the world you are. Maybe in the rich developed countries, there's like this lack of cooperation, not necessarily between fields, but also between people that are maybe not in academics, so maybe like the farmers, and it's really hard to find common ground with people that might not be in science, and it might feel to others that we have constraining needs, where like we have different goals, but actually, of course, we want the same goal, and that is for the livestock and all to be healthy, and for the system to be able to feed people and keep people healthy. So I guess what like Amrish and Fatima also mentioned, there needs to be this basic framework, this basic plan to have an actual thing set before something happens and something goes wrong, like on a regional or national level, and perhaps a global level, depending on which type of disaster you're dealing with. And that the healthcare system doesn't really seem to be able to handle this. I see Amrish raised his hand. Go ahead.
Yeah, no, we have sufficient frameworks and strategies. The pandemic agreement is still being discussed, but we have international health regulations 2005, which kind of like, comply countries to report outbreaks of notifiable diseases. And the pandemic agreement is going a few steps further and kind of like recommitting, but then you also see that it's widely misunderstood on a government level. Like it depends like who is in the parliament. Like I watched a debate around the pandemic agreement commitments of the Netherlands, and it was a complete joke in the Netherlands, very much dominated around misinformation and completely people not even reading the most basic type of things. So yeah, a lot of that, I think like in my experience, like being a frontline responder in a lot of these big emergencies, the biggest bottlenecks are often not tools. They're really the political bottlenecks quite often. And I always urge people in my team and in our organization, and I know the WHO is paying a lot of attention to that as well, is that we can be well-trained professionals, medical, social scientists, etc. But one of the things that we often lack, both as scientists and responders, is diplomatic skill and knowing how to push politicians to do the right thing, regardless of the political climate. And that is a consistent bottleneck. And you see that, like, if you're not trained in doing that and you're in charge of an outbreak team, you won't get hardly anything done.
Yeah. Yeah, and I think
there's no lack of strategies and frameworks around many of the aspects, even for One Health, etc. So I don't think that is the key bottleneck, to be honest.
Okay. So maybe it's more like we discussed as well, the low trust in political institutes, and then also our ability maybe to work together with them and convince them to actually implement these things that we are learning as well. Okay, so I think we discussed most of the answers that are there. So let's go to the next one, unless someone has anything to add. Okay. Let's see. So the next one is, what role does community involvement play in the success of One Health disaster preparedness programs? We discussed it a bit, like using the knowledge of general practitioners as well, and of the local community. So how can we ensure that these communities are engaged? So working together with not just people in academics.
Yeah, maybe I can start as a social scientist. I think this is the area where a smart use of available resources is really crucial. And one example is given by Fatima, simple things like separating the drinking water sources of animals and humans. That doesn't require big science or big tech. It requires simple structures to be put in place. Other things are bed net distribution for anti-malaria campaigns. Typically, bed nets are distributed, but there's very little follow-up in terms of how exactly to use them, how to make sure that each household not just has one bed net, but has several in case there are more people in the household, how you have to employ specific protection measures for kids who either fall asleep during the middle of the day and then also are vulnerable for mosquito bites, or who have to sit up late for doing homework and are then also exposed to mosquitoes approaching them. All these sort of simple things require a combination of use of simple resources and low technical or low-tech capacity in terms of material resources in order to create a big step forward, I think, in types of disease prevention. And this needs community awareness, this needs community programs, and this needs community leaders to be involved. And perhaps we invest too much in high tech and big research and big pharma, and way too little in these kind of low tech, simple but effective kind of resources. And there again, as the example of Fatima shows, we need to pool resources and pool capacities and policies. I mean, livestock typically is an issue for the Ministry of Agriculture, and livestock health is too. But when these come together with WASH, in other words, water and sanitation, and other medical issues, it's Ministry of Infrastructure, it's Ministry of Health, and perhaps even ministries of development that are separate from the others and working in their own silos. A lot of improvement can be made where the community really should be the beginning and end of thinking through what can be effective. And if you do that, I mean, we've done several pilots, you immediately see that the communities are really enthusiastic because they experience these diseases, they suffer from it, and they very happily help to employ measurements when they are proven to be effective, right? And I don't think, let's say, the common approach is just to insert more information into communities, assuming that lack of information is the key thing. It is important, but it always comes with opportunities to do something. So information without opportunities for action make knowledge just a fake thing and not something practically applicable for these people. So the combination of information and resources, or resources and reasonings, is really crucial.
Yes, I think Harro has said it all. Yes, he said it all. For communities to be part of this whole One Health disaster management, yes, they have to, know the reasons why. For example, if somebody has schistosomiasis infection, the person suffers from painful urination or sees blood in the urine, and it is because probably there is open defecation in the community, so they must stop. They have to get a nice place or a toilet facility for themselves, because when you openly defecate, then you are continuing the cycle of infection in the community. So community engagement, one is through awareness, as Harro said. They have to be educated on the implications of their actions and activities in the community. It's very important. So that is what I can say.
Yeah, and I think in many ways, that what Harro says is completely true. Let's take the case study of malaria. We managed to eliminate malaria from a whole load of countries, actually, and we didn't require vaccines for that. We had a basic toolbox of having the right drugs and using them at the right time, not just to treat people and also preventive. Bed nets made a huge impact. And it's not just handing bed nets away, which we tried in the beginning, but then we realized, hey, you need to explain it to people and preferably help them hang it, follow it up. You actually have to ask people to pay sometimes a bit of money to pay for bed nets, because then they better understand why they are important. And this has all been extremely well documented. But again, like if you look at the gap in funding for making basic interventions available, it's huge, and it's growing again. So we see malaria actually from 2000 up till 2015, we saw a steep decline. Then we saw a stagnation, and now in some areas we see an increase because of many different reasons. And actually, it goes for many diseases. Like vaccines typically tend to come into the game very late. So your toolbox doesn't have a tool. So you're very reliant on a community. And it's really like in COVID, like one of the first things we did during COVID was establishing contact tracing. And we knew from the work that we did on contact tracing for hemorrhagic viruses, mostly Ebola, that you need a lot of people for it, which means that you can't have public health people doing it because there's not enough of them, so you need to involve the community. And actually this way you give communities also ownership of solving and something that is their problem. And that is kind of the best way to do community engagement in outbreaks. And there's many other great examples of how to do that. And in that way, there's much more to learn from, let's say, the global South, where out of necessity this has been done, but countries in the North have been super resistant to taking up such lessons. Even in the early COVID pandemic, I wrote a lot about it, and then people said, yeah, but this doesn't apply, for example, to the Netherlands, or it doesn't apply to the UK, but it does, because many of the first interventions are related to behavior. And to change behavior, influence behavior, it's not just sending messages, it's really creating a dialogue. And it's also a great way to combat misinformation, to establish better trust between communities and health responders. So it has super great return on investments, to say it, in many different things in the long run as well.
Yeah, I think this all feeds back like to the resources. It's just so important to involve like the general practitioners and local communities to kind of, like improve the capacity of the general people working on this disaster, but also the ownership of the community, and thereby build trust in institutes maybe as well, and in academia. And for that to make smart use of resources. So kind of it's important to explain the reasoning maybe, and that's why the science side might be important, to explain why it's important, but also then to have these basic interventions and like general solutions to actually implement them in the local in the local region of the disaster. And then apparently we can learn a lot from the global south as well, because it's just lacking a lot in the northern countries to actually involve the communities, and it's mostly like top down, I guess. So thank you for sharing. I think we discussed like the tailored interventions, because it's also case specific. It just depends on which disaster you're dealing with. Like an epidemic is a lot different from a flood, and then early detection, I guess if you have like these, what we talked about with the avian influenza and also other livestock diseases, and you really are able to detect it earlier, then you have, if the plan is already there and the framework is there, you can intervene a lot earlier and prevent it from becoming a disaster, maybe even. And then the education and awareness, I think, helps when you want to explain why this basic measurement is being taken, and involving the local community in that way. And then build trust, and actually use the local knowledge to come up with these solutions. So I think we went over them all. I think this is one of the last questions. So how can we measure the success of One Health initiatives in disaster preparedness? And what indicators should be used to assess impact? So kind of, what is important to use as an indicator when you want to know if it was effective or not, of success or successful?
I think I will talk about monitoring and evaluation. And once again, in a program like mass drug administration, you would have to monitor and also evaluate. Because for a country to be deemed eliminated of a particular NTD, there should be the certificate of elimination based on the WHO standard. So when you monitor, then you can say the disease is no more prevalent, or prevalence has gone down, or incidents have gone down. So if you don't monitor, you can't report back well. And also, if you don't put a surveillance, tag on it, then you can't really know what is going on in these communities. A case scenario is an adjoining district where we conducted our TRC program. They stopped mass drug administration program in 2017 without any transmission assessment surveillance, survey. And the assumption was that they've taken the MDA for over 5 years. So per literature, the disease should go down. So a team went in there to assess whether schistosomiasis had gone down as they are saying. And the report that came back was very disheartening. The prevalence was quite alarming, because they had left the program for over 5 years. And this is due to a lack of monitoring and evaluation. They couldn't monitor, and 2, they couldn't evaluate the program. So monitoring and evaluation is key in achieving the One Health program.
Yeah, I agree with what you said, but perhaps we need to be a bit more specific, because typically, if we measure just the number of a reduction in the number of cases, or even a reduction in the number of deaths, that of course is what you in the end aim for. But indicators should also preferably give some insight in what makes this happen, right? Typically, what you see a lot is that impact measurement of projects is, well, it's on the effective distribution of things. So if we have distributed 100 bed nets and our aim was to introduce 100 bed nets, we consider our project a success, but we have no clue whether these bed nets are used and for what purpose and in the right way, to build on the previous example. So I think these kind of simple uses of indicators is something we need to get rid of. And I know there's a whole monitoring and evaluation industry that, it's a bit more, let's say, sophisticated, as I'm just sketching. But for many projects, it's simple counting of things that have been distributed without properly understanding whether it works and why it works. And I think we need to get rid of that kind of impact assessment, and we should have smart indicators. Smart in the sense is indicators that learn us lessons of what works in a particular context and for what reasons. So yeah, I mean, as both examples have been, both presentations have given examples of how important trusted and well-working measurement and testing is very important. But of course, even if you have a very good test kit that can quickly test whether a disease is prevalent in the blood of a person or an animal, that test kit still needs to land in a health system where these things can be used. So you need to train your community health people, you need to train your vets or whoever. You need to make sure that these test kits are not available just for a few months and then it dries out. So you need your supply chain to have in order. And so it's all quite complicated to have, let's say, an inserted improvement, whether it's material like a test kit or whether it's more social like a new strategy to inform people. To have that really operational and functional on a sustainable, in other words, long-term way. And I think we need to really revise our assessment strategies and monitoring and impact methods to provide deeper knowledge about those sorts of things rather than simple measurements. Okay, we distributed X amount of bed nets, or we trained X thousands of people in X hundred communities.
Yeah, the indicators that Harro just mentioned are the ones that are used most commonly for donor reporting. And unfortunately, that's the only reporting most organizations do. Then they use the same indicators to write their annual reports, both on a government level, like if you look at national malaria control programs. Now, the fact is that assessing impact of interventions is complex for many reasons, because a good season in terms of malaria, so low cases of malaria, might be because you indeed did bed net campaigns, or it might be because it was just a very dry season. And if you don't assess that properly, you can be misrepresenting the effect and the impact of interventions. That said, for some interventions, we simply know they have impact. So if you say like the clinical prevalence in the health facilities that we have, and malaria is a super high burden amongst all diseases, we know that bed nets will work. And they will not eliminate malaria, but they will definitely lower the levels amongst the most vulnerable, just in case the bed nets are, of course, properly implemented and given to the right people and children, for example, to sleep under them more than adults do. But yeah, monitoring and evaluation is general and complex subject. We have tons of projects, medical projects, and we do a lot of it. We generate actually loads of data, a lot of clinical data, but we don't always analyze it because it takes a lot of time. We're now working on automated approaches of analysis. Which means that our medical coordinators don't have to go through Excel files with 1,000 variables and 1,000 records in it. We can automate a lot of the analysis. Just to give you an example, for malaria, which is a biseasonal pattern in most countries that we work in. So you have 2 peaks a year, to say so. We can automate the analysis of the annual data and create a time series analysis, which means that you get an so-called epidemiological curve. So you can see when the peak will start, and basically every year you get more data. So your model becomes a bit more better in terms of like, hey, this is the beginning of the season. So well before that, you need to be distributing bed nets. That's the peak of the season. So you better know that you have enough drugs in house, enough fluids to treat patients, enough diagnostic means. And this will be the time between the seasons where you can focus, for example, on preventive treatment for risk groups like pregnant women and kids. And that by itself is already basically super informative and will prevent a lot of deaths and sickness amongst key populations. And that's kind of how we try to approach it in different sessions. And then, of course, for the more research-oriented questions, that's where we work with a lot of academic groups that are quite strong in epidemiological analysis, but also with a lot of social science groups that can provide a lot of insights that we simply are too generic for. And so our knowledge is broad, not necessarily very much in depth. That's where we look for academic partners across the world.
Okay, Mitchell, to add a little from assessment from a scientific or research perspective is you getting on the field. That is from my perspective, is you getting on the field, taking samples to verify whether there is high or low incidence. Sometimes after a program, as Harro and Amrish are saying, yes, maybe from a donor perspective, the data is there, but from the field, data you can combine and see what is really happening. A case scenario is in, once again, schistosomiasis infection, where, now WHO has given a lot of drugs, but the disease is still prevalent. So now experts began to question why this disease is still prevalent. And some of the thoughts that have come about the hypothesis is that there could be possible hybrid formation and also zoonotic infection in humans. So when you combine the field and the donor assessment, then you can have, or you can question or find the next move.
Yeah, thank you all for sharing ideas. I think it also feeds back to what was said earlier about that it's important to implement like the knowledge, but also to do follow-ups and maybe have this balance between the fancy technology and actually the local knowledge. And that sometimes technology can be very important for the monitoring and evaluation if there's so much data being generated that you cannot like process it yourself all and yeah, need these automated systems to kind of analyze the data and be specific enough with the monitoring, because just monitoring the cases or incidents or deaths might be different from monitoring how many like nets were distributed, and then also measuring the effectiveness of these nets. And yeah, also that gives insight into the actual like cause, but also outcomes of the interventions. And then also maybe not to forget the confounding factors, that there's also other things at play that might affect your outcome besides the intervention itself. And I think, yeah, that's kind of what was said here. The ecosystem health, we didn't dive that much into it, but I think it's like part of the One Health approach. It's one of these indicators that could be important to measure as well. The disease incidence was discussed, and vaccination coverage could then also be important as a more general assessment into actually the effectiveness of the campaign and not only the outcome of the vaccinations. And then not to focus too much, or maybe focus enough on the donors because they are needed, but also to not forget the things that we have to measure for ourselves that are important to measure the effectiveness of our programs, not just for the people that are financing the program, but also to actually make sure it's effective what is being done. I think we discussed the responses from the audience as well. And if the speakers don't have anything to add, I think we will slowly wrap this up as well. So thanks a lot. I will show a few feedback slides to kind of, close off the session. And then it's time for the rest of your, like Fatima said, morning, afternoon, or evening, depending on where you are. Okay, so I think that today's question we kind of had was, what is the added value of the One Health approach across these different phases? And the thing was that it's quite case specific and a balance between fancy technology and actually local implementation of knowledge, and not just measuring what's happening right after or like during the pandemic, but also after the disaster and long-term kind of evaluation. The questions are always a bit hard to answer on purpose because there's just so many factors at play. But I think we tried our best to kind of dive deeper into this topic. So I want to thank the speakers for doing that. And then for our cohorts, of course, in the WhatsApp group, we are curious what you're thinking of this panel discussion type of event as opposed to more a webinar with a Q&A. So please let us know in the WhatsApp group what you prefer. And then our next event will be about food safety and security, and how it is necessary to tackle problems that are now kind of ingrained in our current agricultural and food systems. One of the speakers will be Benny Osborne. He was the Dean of the School of Veterinary Medicine at UC Davis. He is now retired, but he was and is still involved in research focused on infectious diseases of livestock, zoonotic diseases, and also foodborne pathogens, and then the ecology of the infectious agents. And the rest will be announced later. So I don't know if there are any remaining questions. I will take a quick look at the chat. I think we had most of the questions already. So thank you all for joining. And I want to give a great thanks to the speakers for being here and giving their presentations. I learned a lot. So I hope to see you another time. And have a nice day.
Have a nice day.
Bye-bye.
Bye-bye.